everyone see that one?
Yeah.
We all see?
Cool.
Beautiful. Yeah, so see, we've got a CPG today to talk about all about the knee ligaments and sprains.
Sorry, Jack, you're just breaking up a bit,
sort of
hopefully.
Bits and pieces throughout the
That's better.
Diagnosis of a knee sprain, according to I'm on my own phone, so maybe we'll see how it goes for a little bit.
Yeah, that's better.
So
Cool.
diagnosis of a knee ligament injury is usually based around the history of the injury, the passive knee laxity, so our ligament laxity tests, joint pain, and then movement coordination impairments. And that is a level of evidence. Coming into differential diagnosis, clinicians should suspect, diagnose, we should, be careful of serious pathological, and when people report these impairments and limitations, the previous little paragraph there. So in the exam, a couple of these questionnaires or surveys recommended. So we've got the International Knee Subjective Knee Evaluation Form, or the IKDC 2000 for short. We've got the one that we use here, the KOOS, the Knee Injury and Osteoarthritis Outcome Score. And then there's a couple more after that, and that is B levels, so pretty good evidence as well.
So, hey girls, so Avi first, is the KOOS still what you utilize the most?
I think it just like depends on where you're practicing and like personal preference.
What's your personal preference?
I don't know if I've ever really used the KOOS. I mostly use the LEFS because it's just easy
generic.
for, once you kind of know one of them, it's easy to use it for all lower extremity stuff. So
hence why it's called LEFS.
Yeah, so I don't know. I mean, that doesn't mean it's necessarily like the best outcome measure for everything, but when you have to get through it pretty quickly, it's easy if you can already have one that you use most of the time.
Nat, do you use any of those? Or have you seen that?
Those are those the questionnaires that you're referring to?
Yeah.
No, I've never used any sort of questionnaires really like that.
Yeah. I tend to use the LEFS only since Avi sort of brought it to our attention for the exact same reason. It's just easier to be familiar with something. But did you use the KOOS, Jack? I don't remember using the KOOS. Actually,
I thought we had it first, but I think we changed it to the LEFS.
Okay,
Just to have like them all like leg injuries as one questionnaire. That makes.
Yeah, I think that's what we do here now. We'll have to check. I guess Avi's legacy lives on. There you go, Avi. We're just doing LEFS. By the way, discussing knee ligament injuries, just for you to know, Riley, the three of the guys have all had a knee reconstruction. So it's a really interesting topic to talk about. Avi has, Nat has, and Jack has. So just think that's very interesting that the three physios have actually had knee reconstruction. So we'll talk about the evidence going through, but please draw upon your personal experience, especially if we get to E-level evidence. I'd love to hear your thoughts.
Also found this interesting. So there's a ACL return to sport after injury questionnaire. that is valid in sort of patient-reported outcome measures to assess the psychological factors that may hinder return to sports before and after interventions intervened. So I haven't seen that one, but definitely should have a look at it when we do get an ACL patient come in, especially now that sports season's coming back.
Yeah.
So, physical performance that clinicians should administer involves sort of single leg hop test, e.g. single leg crossover hop for distance, the triple hop for distance, and the 6 metre timed hop. And these can identify patients' baseline status relative to pain, function, and disability. They can detect side injuries, global knee function, and return to sport activities, and monitor changes in the patient's status throughout the course of treatment. So I guess they're all, easy, good tests to use. We've got the MAT test, and definitely when we start talking about IVES, all these can be used.
Yeah, I really like the physical performance measures. I feel like, and Riley, just for your benefit, what we talk about here with physio is that we get people to a certain point and then we don't take them to the end. I'm just wondering people's thoughts about those performance measures. If we agree, disagree, is it enough? Maybe not. Do you want to jump in first, since yours was fairly recent? What are your thoughts about those impairment measures and return to sport?
I think those are really great. They can be very functional as well, depending on if you have an athlete that plays a sport that, for example, does a lot of jumping, or single-legged jumping. But I also don't think that from my own personal experience having 2 ACL operations, I don't think they use them enough or test enough in that regard.
Yeah, absolutely. Avi, what are your thoughts about the impairment measures and ACL end of stage rehab, I guess?
I think they're pretty important to do. I know there's like a ton of different ones you can do, and I think it's important to be like sport specific as much as you can, but I'm not really sure there's a whole lot of like research on, I don't know, I guess it depends on the test for different sports. But at my last clinic, we used not all of those, but like a bunch of different ones, like cutting and stuff like that too, and like jumping off a box and just looking at like landing and stuff like that as well, which I thought was helpful. But when I had my ACLs done, the first time I don't really remember doing any like tests. I know I did stuff like that for like training, like to get back, but I don't know if anyone actually like looked at like my knee position or measured the distance or like did anything to tell me that I was like cleared to return to sport. And then the second one, I never really finished PT, so I don't know what happened with that. But I just wanted to play, so I kind of skipped the rest of PT and started playing.
No, you didn't.
Yeah.
One thing I want to add about that, because a lot of times the unaffected leg becomes so weak to the point that that it becomes more susceptible to, for example, ACL injury. So that's why I think those tests are so important as like a baseline. Also to compare the unaffected side. So like before surgery, if you can, after surgery, and then of course, like, well, before surgery, you can't really do it right after surgery, right? But like, yeah, to get an idea as well.
Absolutely. Before I say anything, Jack, do you have any insight from your experience?
So my internet just had a moment there, but yeah, I spoke to Harvey. I feel I did a lot of sort of single leg jumping and hopping for my exercise and rehab, but I don't think I was ever really measured or, like, you know, kept a score of what, you know, I was doing for each hop test or whatnot. But then again, I wasn't really returning to any sport. I was just returning to function. Yeah.
I think to bring it back to it, I think what Avi said about being specific to the patient's goals, I think is very important, because those tests are fantastic. And when you can connect the why, how it's linked to, you know, getting back to return to play or even just running or different elements, I think that's really important. I just think in general, it's not done enough. I think as well, which will a story, you know, for another time, but I don't know how it works in America, guys, but like I certainly don't have access to the high-end weights and stuff like that in here, and I have no problems. I had a really good ex-phys person I used to refer to. Dan was not here during your time, yeah, I think Jack, the thing's just things gone. That's all right. Yeah, really good to just really good to take it to that next level for return to play. And just quickly on that, is there a pathway for that in America, guys, or do the PTs sort of really finish the job with that high-end return to play stuff?
I've mostly seen like the PTs doing it.
Yeah, I'm talking about like lifting the heavy weights, the deadlifting, the pure change of direction, gym work and stuff. Yeah, cool. Nat?
I don't think I quite got your question.
Just sometimes when you're finishing the job with an ex-rehab protocol for ACL, sometimes I would refer to like a strength and conditioning or exercise specialist.
Got it.
To just put the icing on the cake. I was just wondering if you've seen instances of that, or physios actually more finish the job in the States.
From my own experience, I was never referred to anybody, but I think that also depends on, you know, like, does this person have the money to pay on their own to see a strength and conditioning coach? How elite is this athlete? Do they have a team set up for them, like, that you can kind of like communicate with? So I think it really just depends on who you're dealing with. Yeah,
absolutely. I guess the take-home message is finish the job. Too early in my career, I'd get people to a certain level, then they just drop off, and I'd never follow up to see how they were going. But we know if they do it, you know, if they don't do the right thing, eventually we'll catch up with them. So yeah, good to know. All right, let's power through, Jack, if the internet still is okay.
Some physical impairment measures. Clinicians should assess
Jackson.
Likely stability, lower limb movement, muscle strength, knee effusion, and knee joint range of motion. To get B level. So moving on into the interventions, we've got, starting off with the C level evidence, continuous passive motion. So clinicians may use continuous passive motion immediate postoperative period to decrease construction. So that's, yeah, just moving the knee through its range, trying to recruit. Another C level, early weight bearing. So clinicians may implement early weight bearing as tolerated within a week after surgery for patients after ACL reco. Any thoughts around early weight bearing?
I'd love to hear it from the people that have been through it. What do you think?
I don't know. I think that kind of depends on your surgeon more than. I'm not really sure.
Yeah. What about the different people? What about yourself, Avi? What would you have found having gone through it twice?
I don't really remember. I don't think I was really weight bearing much the first week.
Yeah. It's an interesting one. That's why it was unusual for me. I don't get weight bearing too soon. That's why it's interesting. Nat, what are your thoughts? Cool.
Yeah, it definitely depends on the surgeon. I think I'm just trying to remember. Well, the first time I had my ACL, I was really my first ACL surgery. I was only a teenager, so my recovery, like comparing that to my later 20s when I tore my other ACL, is just completely different. Like how quickly I was recovering, but just specifically with weight bearing, I can't really say too much.
Yeah.
Like, I mean, it isn't. It's also the sea level, right? So that's not really.
Yeah. I just wouldn't have done it. I wouldn't have. Yeah. I wouldn't have done it within a week.
Try to avoid it to be safe on the safer. Yeah.
Yeah. I think like, I don't know, for me, I've kind of, I mean, like most people are on drugs, plus like they might not have the quad strength to like actually really support them very much. I mean, I'm sure they're not saying like full on weight bearing within 1 week, but yeah, I don't at all. I mean, a lot of people are also just in a lot of pain, so weight bearing doesn't really make it feel great usually, I don't think.
Yeah.
I guess with the length of time of an ACL rehab after post-op, it's 9 months to 12 months. I can't, in my limited experience, see how getting off crutches in a like 7-day period, a day earlier, or 2 days earlier is going to make too much of a difference. But I think it's more about the psychological, like you're trying. Like I was very encouraged to get off crutches as soon as I can by my physio, but I think that just helped me get that motivation to try and rehab it early, because all that early exercise is key, but it's all about the psychological means. But that's just my take on it.
No, this is why I like chatting about it, because I see something like, oh, I've never seen that before. The next one's going to get controversial, because I'd love to talk about that. Knee bracing. Can I talk about this for a second, Jack? Because it says,
go for it.
It says, clinicians, and I might just talk a bit more, Jack, if you just screen, just because you've been cutting out with me. Clinicians use functional knee bracing in patients with a deficiency. C-level, D-level clinicians to elicit and document patient preferences in the decision to use a knee brace. Wow, okay. And clinicians may use appropriate knee braces for patients with acute posterior cruciate ligament injuries, severe MCL injuries, or PLC, or posterior corner ligament injuries, and that's F-level evidence. I have thoughts on this, so I will talk last. Avi, you go first. You've seen a lot of knee people. Are we bracing in the States a lot?
Yeah. Well, I actually had to do for like prosthetic and orthotic class. My group had to do a presentation on knee bracing for
How
ACL
appropriate.
injury.
What did you find?
So, basically, there's like pros and cons, but essentially bracing for an ACL post-op really doesn't make any difference on re-injury rate. So that's why I think they say like the patient preference thing, because some patients are going to feel safer in a brace regardless of it, if it actually makes them safer. But most of the evidence is saying it doesn't really matter, except there were like a couple studies on like skiers, I think, that said it might be beneficial for skiers, but that was like the only sport we really found anything for. And then, but then for ACL deficient knees, I think we found some articles that had pretty good evidence for using it for patients that don't have an ACL and wanted to play like sports, basically.
Really?
Yeah, like if you don't have an ACL and you want to run around cutting and stuff, I feel like it kind of makes sense. But if they're not trying to go back to a sport and don't have an ACL, then there's not much of a point to having the brace.
Yeah, and I guess it depends on the sport as well and the limitations of the brace. Here I'm, thinking these functional braces don't have to be the big metal and thing ones. They can also just be a bit more supportive to allow for sport, I guess, if you don't have an ACL. Interesting. That was my thoughts around it. Nat, do you have anything to add?
I felt a lot safer having a brace like right after surgery, but when it comes to like actually once that brace is off, I didn't want to wear anything else. I just wanted to really like focus on rebuilding my strength in my knee and not have to like also psychologically like feel like I need to depend on a brace. But I think it also really depends on the person. If they feel like they're performing better and they're doing better, I think that's really important for trying to avoid injuries in the long term. But I can't say how much I know, like in terms of like how much weaker is the person if they have to rely on a knee brace.
Yeah, that's absolutely. That's really interesting. Obviously, Jack, you didn't wear a brace, did you, post your surgery? Oh, he's just cut off there for a second. That's all right. We can stare at his frozen face. Sorry, Jack, you cut off. He's just next door. He didn't wear a brace. My thoughts just quickly, because I've been a physio for a little while now, it makes me feel old. When I started in 2011, they were bracing almost as a usual function and a usual thing. And very quickly, I'm lucky, as Avi got to spend the time with Dr. Brett Fritsch, who you saw. You can see he doesn't brace anymore, and he just said there's no point. However, one of my good friends had a PCL reconstruction, which is very uncommon, but we decided it was the right move for him. And Brett did brace him in a fixed position because he said the knee needs to be in a straight position to allow the PCL to heal and catch. Is that familiar to? Yeah, you're nodding your head. Is that something that's familiar to you?
Yeah, I've like heard that for PCL that it should be in a brace after surgery. But so when I had my ACLs done, I didn't have a brace after surgery. I didn't have a brace until I started playing sports again. Yeah, and they just were like, wear this brace when you play for 6 months.
How did you feel? Like, for example, I would even hop on the bus after my surgery, or like, and people would like knock into me and stuff. And did you ever encounter anything like that, or did you try to avoid those situations so it didn't really matter if you had a brace?
I don't know. Well, the first time I was in high school, and I don't really remember. I remember being on crutches for like maybe like a week or two. So it wasn't like super long time. And both times I did it, I was like full on playing lacrosse in 6 months after the surgery. So it was like a pretty quick recovery time compared to a lot of the 9 to 12 month ones. Not saying that I necessarily should have been cleared to play sports again, but
that's how I was after my first. But not after the second one, because it's later.
Yeah.
But you'll draw upon those experiences when you help rehab people, and I think that's that's really important and really cool. And you see, they're going through.
Yeah, but I don't think the bracing is super crucial for ACLs. I think it's really more psychological, if anything.
Yeah. I think, and I think it's just like taping and stuff. If it gives them permission to take shortcuts or feel like they, can work through deficits without it, I think it's actually not a good thing. So it's just something to keep in mind. But super helpful that you actually looked at the research for it. So thank you for that, Arby. I was just going on my clinical judgment and what I've seen, but you're like, I actually looked at the evidence and this is what it says. I'm like,
Yeah.
Sweet. Sweet. I'll keep going because Jack's internet's a bit patchy. So he can come in and out. Can you hear us, Jack? We good? Sort of, maybe not. So interventions, all good. Interventions, immediate versus delayed mobilization. Oh no, the delay of the internet, that's all good. Clinicians should immediately mobilize within a week after ACL reconstruction to increase joint range, reduce pain, and reduce risk of adverse responses of surrounding soft tissue structures, such as those associated with extension, range of motion loss. Agree? Disagree? Yeah, I think that's a straightforward one. Well, like my sister, by the way, is having surgery next week or week after. So remember we talked about her cyclops lesion, and a big thing, and she said she wishes she addressed it earlier. She just would not get full extension, and something just wasn't feeling right, and it felt like a block. And again, if things aren't going right, it's always good to talk to the surgeon about that. So yeah, she's going back in for revision. But the good news about it, because it's now an arthroscopic, really quick procedure where they just literally shave down around the area, she's looking at only a 4 to 6 week recovery for that, and then she'll sort of be back to where she was. So it's not the end of the world. And functionally, she was doing quite well, but she just lacked that extension. And that's huge. That's what I see a lot. I've also seen with some of Brett's, sometimes even you can get what we call a fixed flexion deformity. So because the hamstrings are so tight, they just don't move as well. So we've really got to make sure we loosen and get things going. And I remember, I think Dr. Fritz said, remember how he was doing the double bundle, or was it the quadruple bundle? Yeah. So he really tightens down on that ligament, folding it over itself twice before putting it through for the hamstring graft. So that's a pretty straightforward one. Only B-level evidence. I thought that would have been A. That's all right. Cryotherapy. This is interesting. Big fan of cryo. Clinicians should use cryotherapy immediately. I would love to see the papers on that. Have any of you guys had cryo, by the way?
Yeah, it just means ice.
Oh, is that just pure ice? Sorry.
Yeah.
Well, cryotherapy is just like anything that's cold.
Okay. Cold. Sorry. I was thinking more. What was I thinking?
Like an ice chamber.
Yeah, the ice chamber. Yeah, the compression chambers, which are really cool.
I actually had. It was like kind of like the Game Ready, but it didn't do the compression. It was just the cold, like ice water flowing through for a while.
Oh yeah, that's pure cryo. Yeah, but good to know. And that's the Game Readies are fantastic. You got a Game Ready, Jack?
No, I had what Ivy had, just not quite the compression, but the
cold water
ice wrapped around thing.
Yeah.
Nice.
It was my best friend there for a few weeks.
I can imagine. I can't wait to talk about one. Let's go through all the A ones. So therapeutic exercises, weight-bearing and non-weight-bearing, concentric and eccentric exercise should be implemented within 4 to 6 weeks, 2 times a week for 6 to 10 months to increase thigh muscle strength and functional performance. Of course, we believe in that. We don't really need to talk about that. That makes sense. That's just rehab, is it not? Unless I'm misinterpreting it. Yep. I'll take that as a yes. Here's an interesting one. Neuromuscular electrical stimulation, and then we can link it into the re-education because they sort of work hand in hand. So neuromuscular electrical stimulation should be used for 6 to 8 weeks to augment muscle strengthening exercises in patients after ACL reconstruction to increase quad muscle strength and enhance short-term functional outcomes. Avi, I think I spoke to you about this when you were here. do you guys use neuromuscular electrical ES in America early on with ACL patients or post surgery?
I think some people do. I don't think I had any patients that were ever like immediately post-op ACL. The ACL patients I had were like further out, so it wasn't.
Yep.
And I didn't. My PT didn't do it on me.
Okay. Cool.
So
no personal experience. What are your thoughts on? What are your thoughts on it though?
I mean, I think it's fine. We learned about it in school. I mean, we did it on each other in school a little bit, but
yeah, cool.
Yeah. I mean, it has good evidence for it. So
yeah, I like that has good evidence for it, and we'll talk about that in a second. Nat, do you have any thoughts?
So when we were just talking about any like electrotherapy type stuff, right?
no, an MES is different than like a TENS thing or something. It's like specifically the parameters are for like making a muscle contraction.
Oh, right.
Not for like, pain.
Yeah, it's not the okay. Yeah, so it tells you when the muscle is firing, basically. Is it that one?
It's like the parameters are just different, so it contracts the muscle. It like stimulates the neurons to like actually contract the muscle.
So actually, I think I had that done after my first operation simultaneously while I was being iced, because just to like save time, and it felt really good, and I could feel my muscles like contracting while the ice was on there. I liked it, but I think it was more psychological than I could say it really helped in the long run. But I mean, I guess they're saying it's really good. So
I think the key is actually, before I talk, Jack, do you have any thoughts?
Yeah, personally didn't have it done on me, but I can imagine how it would benefit someone in the early stages, being just the right person, I guess. But 6 to 8 weeks of it seems a bit much.
Or yeah, I'm intrigued with the 6 to 8 weeks. I'll tell you my thoughts. Just Nat, just for your benefits, neuromuscular electrical stimulation and re-education, I think, are two separate but similar principles. So my understanding is the stimulation, as Avi said, was the literally getting your muscles to contract, and the re-education are the ones where literally you're trying to turn the muscle on and it sort of beeps to tell you that you're getting quad activation and stuff like that. Does that make sense?
Yeah.
But am I right or is that wrong?
Wait, are you like looking at the neuromuscular re-education thing?
Yeah.
I don't think the neuromuscular re-education has anything to do with electrical.
Oh, okay, so that is pure muscular education.
Yeah.
Yeah. Okay. Cool.
I think I haven't read the full article in a while.
I think it's just like exercises and exercises.
Right. It's just okay. That's good to know. Yeah. But there are different elements, but the stimulation element, I think, is clearly the one's forcing a muscle to contract. I can only go on the few people. Yeah.
Not being done voluntarily, basically.
Yeah.
It's not.
But what's it? Sorry, one at a time.
Like, it isn't voluntarily contracting the muscle. The machine is doing it for them.
Yeah. But as Avi said, it's very different from TENS, and that's what's really important to point out. There, we're not going to start after this talk just putting everyone on TENS. it's not how we operate.
For 6 to 8 weeks.
For 6 to 8 weeks. Oh, can you imagine? Because A-level evidence from the state says it. No. Ashu had the PCL reconstruction. I just gave him one of our neuromuscular ES units, and he just said it helped him tremendously when he couldn't do much, and then it helped him do his exercises, but it helped his range of motion. My sister had it during her ACL, so yeah, I think there's obviously something to it, but it has to be put together with the other elements to it. So that's about it. That was a bit of a longer one. I think there was some cool discussion there. Can I go around the room and just get your quick take-home message take home. Yeah, the one thing you'll take from today's talk, I guess, Jack.
Someone else go. I'm trying to find something in the paper on a different screen. Hang on.
Right. Cool. No, Nat, have you got something?
Yeah, definitely. Like with the knee bracing, that whole concept was new to me. Not having one right after, and then so that's interesting. Something that I also think is not really discussed. Well, it wasn't discussed with me, and I had mine 2 years ago. So, and then, yeah, I just have to remember. I always confuse all those electro things, and just there's a lot of terminology with that stuff, so I get confused a lot. So.
And it's all good. Before everyone throws the book at us, if they see this recording and they say, "Oh wow, Ives just does 10s on everyone for the first 6 to 8 weeks of an ACL rehab," let's not go down that pathway. Avi, yeah, any take home? Obviously, you're pretty familiar with this stuff. What struck out of you today?
I just think it's really important to remember that return to sport testing is like really important before actually sending your patients off to go play full on, because I mean they're already like at risk for re-rupture, and like it just, the studies have all shown that like once you tear your ACL, you're at risk for re-rupture or rupturing the other one within like I think like the first like 3 or 5 years after surgery. So I think it's just really important to make sure your patients pretty much as good as they're going to get before they go back.
Absolutely. Don't hesitate to be conservative for it. Even if they really want to play lacrosse, you probably should, get them to finish the job. Sorry, Riley, I know this was a bit content heavy, but did you pick up anything from today?
Yeah, that was just like a lot. Like my brain
your brain must be like boom.
Not so much. But yeah, it was just interesting to see like what they recommend post-op, and then like how all you guys were treated post-op and how it's like kind of different. So it's just interesting to see like what some people do, what others do, what works the best, if you know what I mean.
Yeah, no, sounds great. And Jack, do you want to wrap it up?
Yeah. Just following up from what Avi said, how important the return to sport sort of testing is, but then the physical testing, but also the psychological testing, because I'm sure as Avi and Nat knows that, you can be 100% physical, but it's a whole different story mentally when it comes to an ACL return to sport. So having that return to sport sort of questionnaire about psychological readiness is just as important as the physical stuff.
Oh, fantastic, Jack. What a great way to finish it. And that could be a whole other can of worms, the psychological recovery processes around ACL rehab, because when you're down a 9 to 12 months journey, it takes its toll. But thank you all.